My name is Meena Kalluri, and I'm the Medical Director of the Multidisciplinary Collaborative ILD Clinic at the University of Alberta. ILD stands for Interstitial Lung Diseases, and it's actually a group of about 200 plus diseases that fall under this category. And essentially what happens in ILD is that the lungs, or the air sacs that are located inside the lungs, they get inflamed and eventually they get scarred. So there's a combination of inflammation and scarring that's happening within ILDs. Patients often get confused between ILD, pulmonary fibrosis, and other conditions. So pulmonary fibrosis is a type of ILD, and it's the type of ILD where there's more scar as opposed to inflammation. Now, pulmonary fibrosis can be of a variety of different types. So for example, if you've gotten some chemotherapy drugs for cancer treatment, if you've received radiation in the past, if you've worked in different sorts of industries, for example, if you were in the mining industry or you were exposed to asbestos, you're a farmer. So all those kinds of exposures can cause scarring in the lung, and they can all give you what we call pulmonary fibrosis. So let's imagine that you now have scarring in your lung, but we don't know what the cause is. We can't figure out what the cause was that started the scarring to begin with. Now that specific type of lung scar is called idiopathic pulmonary fibrosis. So it is a type of ILD, it is a type of pulmonary fibrosis, but it is very specific. So let's start talking about some of the symptoms. Now most often patients will present with symptoms of shortness of breath. We call it dyspnea. Or exertional dyspnea, which happens mostly when they're trying to do stuff. So for example, if they're trying to go up a flight of stairs, if they have a physical job, they might experience symptoms of shortness of breath doing activities which didn't cause those symptoms before. Sometimes they'll have a cough. It could be a dry cough, or it could be productive sometimes. Lots of times patients also present with fatigue or just being tired. They may not really have shortness of breath or cough per se, but they might notice that they're getting more and more tired doing the same sorts of things that they were doing before. These are the most common symptoms, but sometimes they can also present with some chest tightness, loss of appetite, weight loss. But most often they also notice things that change within their bodies. For example, their fingers can get really round and thick. It's called clubbing. Sometimes they can notice that. They can also notice their lips or fingernails turning blue with activities, so they can notice that also. So most often when patients have any of these symptoms, they present themselves to their family physician or their family doctor. And the family doctors will then make sure that they've ruled out most of the common conditions, because these symptoms of shortness of breath and cough are quite common. They can occur in asthma, they can occur with emphysema, bronchitis, or even heart disease, which are far more common than IPF or ILD is. So the number one job is to make sure that you don't have any of those conditions, and your family doctor can easily do that by talking to you, by examining you. They might put a stethoscope on your chest and listen to the lung sounds. They might hear what are known as crackles, and they might order some breathing tests. And the breathing tests will help us determine what kind of lung restriction you might have. And once those tests confirm a problem, your family doctor might refer you to a specialist, to a lung specialist, who will then do more testing to confirm diagnosis. So examples of what are those additional tests. So let's imagine now you've reached your specialist's office and you have already done an X-ray that shows a scar. You have some breathing tests that show that your lung volumes are small, because most of the ILDs, because they cause scarring of the lungs really get stiff, they get thick, they get hard. So they're not blowing up like a balloon. They're not contracting and expanding as they should when you normally breathe in and out. So in those situations, you'll notice problems with the breathing tests. We call them restriction, which means the lungs are not expanding, they just get stuck at a certain point. So the volume of air inside your lung, the amount of air that you can breathe in, starts to go down. The amount of oxygen that goes from your lungs into your blood vessels goes down. So those are the three specific things we look for when we're doing these breathing tests called PFTs. And then your lung doctor might order a very, very specific type of CT scan. It's called a high resolution CT, so HRCT. So that's a very specific type of CT scans that we use quite a bit to diagnose ILDs. So the CT scans will reveal a certain pattern of scarring. And that's when we use other specialists like radiologists to help us figure out what pattern of scarring you might have on the CT scan. And in some situations, when the CT scans and the examination is not helpful, we might consider a lung biopsy. So we might ask one of our surgeon colleagues to help us out and get a lung biopsy done. Blood tests could also be ordered. And in some situations, we might also engage other specialists like rheumatologists or occupational medicine specialists. So really the process of diagnosis is not straightforward. As you can imagine, it's complicated. And this is one of the reasons why I think the diagnosis of interstitial lung diseases or pulmonary fibrosis, IPF, takes a while. And we know from research that on an average, it takes about a year to 2 years from symptom onset to diagnosis. And this is where I think the scientific community is focused. We want to make sure that we're raising awareness amongst the patient community, amongst the physician communities to reduce this time. Because the sooner you get diagnosed, the sooner you can start therapies and hopefully get good outcomes. So very earlier on in my career, when I started to do ILD care and started to meet patients and look after them, it became very, very clear to me that the moment they receive a diagnosis of pulmonary fibrosis or IPF or any other types of ILD, it's really a life-changing event for them. It brings up a lot of emotions. People are angry sometimes, they are surprised, they're grief-stricken, because it is a tough thing to handle when you're told that this disease is progressive, that it doesn't have a cure, and that we can't even predict at what rate your disease will progress or how you will decline. There are no fixed timelines. They have to grapple with a lot of uncertainty. And that's one of the hardest things to do personally and professionally, even in medicine, when you can't really predict or tell a patient how many months or weeks or years they have to live. So I found that it's very important for us as healthcare professionals to not only do the medical side of things, but also be there to support our patients emotionally as much as we can, and to provide education and support not just in clinic, but even outside. Maybe by offering nurses as contact persons and joining them in rehab programs. And this is where the need for the support group really became very, very clear. Because no matter how much you do, I don't think it's enough when you do it in the limited constraints of clinics where time is of the essence. So I find that patients actually benefit when they can sit, take time to listen to one another, to be able to share their own experience, and basically engage in a very safe environment where there's mutual exchange of information. They can be exposed to other types of learning, and this was the reason why we established the support group, because we knew that the patients were feeling isolated, they were feeling alone. Particularly here in Alberta, there's a lot of patients coming from rural communities that are driving sometimes 3, 4, 8 hours. So it's important for them to have access to this kind of support that is local. It's very important because then people learn from each other. They understand how to cope, how to survive. They can actually share little tips, tricks that I may not have knowledge of. So this is why I think it was very important to develop the patient support group, and I encouraged it. It was one of our caregivers who developed it, and through the Lung Association now it's running very, very successfully. And the other component is the caregiver support that happens in these support groups. Sometimes they have sessions that are dedicated for caregivers. And I know they are the unspoken sufferers in this condition. It's the caregivers and the family. We try and engage them and involve them in decision making and in care as much as we can. But I think more needs to be done and more can be done, and I'm sure it is being done through these support groups. So my message to patients would be that yes, this is a tough diagnosis to have. This is a hard condition to deal with, to live, to treat, to undergo, but there is always a reason for hope. It's not always about looking at the glass half empty or half full, but to know that it's refillable. And I think that's how we need to go forward until science brings us new hope in terms of cure or in terms of medications. I think we have plenty by harnessing the incredible human spirit to keep moving forward and to live life as best as you can, as fully as you can.